registered therapists in Canada. And then we kind of think about and reflect on how these new regulations affected spiritual care, training, education, and practice in Canada, specifically in Ontario, and how educational institutions prepared themselves to respond to these growing needs. And then we will go over of PTSD, post-traumatic stress disorder, and post-traumatic growth. I have specific cases, and I would like to review some of these cases in order to reflect on evidence-based research in spiritual care, education, and practice, which is kind of a growing need, especially when we work with people who suffer from different mental, emotional, cognitive, and behavioral problems and spiritual distress. Then I will, first of all, I would like to start with Rumi's reflection. Rumi says that the cure for the pain is in the pain. Of course, when Rumi talked about this, he didn't want to ignore the pain of the sufferers, but he simply invited us to look for growth and resilience, and how these kind of internal capacities can help us to grow out of our traumas. Overall, Rumi's reflection also encourages us to look at trauma from transformative perspective. Especially my case studies in this presentation focuses on women. We live in patriarchal societies, and we see horrible traumatic experiences of women. They suffer of genocidal rape during wars. So this, it doesn't happen in, not only happen in medieval times or prehistoric times, but this kind of genocidal rape against the nations happen in 21st century as well. So looking at this, so I also reflect on the role of spiritual care providers and how they can use spirituality to help the clients, and also kind of connects them to other mainstream sources of help, and use different modalities of psychotherapy, specifically in Ontario, because majority of spiritual care providers get trained and practice these modalities. So unfortunately, I missed the chance to meet with Professor Snodgrass today, because some parts of my presentation today come also from my chapter in the book that John Holton and Snodgrass authored. The title of the book is Reframing Trauma as Psychospiritual Theory and Theology, specifically from the spiritual care perspective. So coming back to CRPO, which is a main, one of the main organizations, colleges, associations in Ontario that shape spiritual care training and practice in Ontario. So they are the ones to define control act of psychotherapy, and they are the ones to proclaim it. So psychotherapy in Ontario is one of the 14 Control Act or healthcare activities, and this Control Act is restricted only to members of CRPO in order to practice psychotherapy and to claim registered psychotherapy or qualifying psychotherapy with CRPO. Of course, other colleges allow, and the regulation also allows some professionals to claim that they practice psychotherapy, like social workers in Ontario or some occupational therapists trained in mental health training. However, they cannot call themselves registered psychotherapists. So the title registered psychotherapist only exclusively entitled to members of CRPO. The CRPO aims to protect public, especially in terms of potential harm by mental health professionals. But for me, when we reflect on this, we also see a new dynamics of traditional separation between religious institutions and the state. We have seen these kind of discussions and dynamics, especially in 2012 and 13, when majority of spiritual care providers in Ontario wanted to join CRPO and get the title registered psychotherapist, but some they were careful and they didn't want to join CRPO. So again, for me, there are many benefits to join College of Registered Psychotherapists in Ontario. And the reason is that it gives additional kind of accountability to religious leaders, chaplains, pastoral counselors within the mental health practice if they want to practice regulated psychotherapy practice in Ontario. So CRPO is the main governing body. It's a health regulatory college of government of Ontario. So it affected spiritual care activities, and I will tell you more about that. So, for example, the new requirements and the titles to join CRPO, and also how many educational institutions in Ontario prepare themselves to train a new generation of spiritual caregivers so they can join CRPO. So an example of for this kind of education institutions, I can give Emmanuel College of Victoria University in the University of Toronto, because after this, we kind of, our Master of Psychospiritual program, for example, has been transformed significantly in order to respond to these changes and also to respond to the needs of spiritual care providers coming from diverse backgrounds. These spiritual caregivers, they wanted to join CRPO. And also, interestingly, majority of hospitals, main hospitals in Ontario, like CAMH, for example, Center for Addiction Mental Health, um, and other hospitals in Ontario, wanted the spiritual care providers to get RP, registered psychotherapist title. So coming back to kind of comment on how CRPO also triggered certain discussions in terms of separation between religion and also state is that so in 2013, for example, Ministry of Health and Long-Term Care advised the Transitional Council, they were responsible for establishing regulations on the CRPO. So they say the new college should focus on regulating the profession of psychotherapy. And then CAS, Canadian Association of Spiritual Care, is an association where they give kind of certification to spiritual care givers in Canada to practice spiritual care. So in their letter to Ciaran McKenna, Chair of Canadian Association of Spiritual Care, Joyce Rowlands, Register of CRPO, stated that those who provide pastoral or spiritual counseling are not required to be regulated health professionals under the RHPA, Registered Health Providers Act. However, again, many spiritual caregivers in Ontario specifically wanted to join CRPO. By this desire to join CRPO, we also notice how it affected our professional identity. So in this context, I would like to provide some insights into definitions, how we see these definitions, particularly in Ontario, and overlaps and differences between spiritual care, counseling, or psychotherapy. So, giving you some definitions from Canadian Association of Spiritual Care in Ontario. So, spiritual care what we mean by spiritual care is that, quotation, spiritual care embraces a holistic approach to care, attending to individuals' beliefs, values, behaviors, and experiences related to spirituality, religion, and culture. Spiritual care practitioners inspire hope, empower healing, and make space for meaningful change. Spiritual care is practiced through the assessment and treatment of issues specific to each person. I would like you to pay attention to specific words and terms used in these definitions, and then how this kind of what these terms and words mean in the context of psychotherapy and counseling. So psychotherapy then, according to CRPO, is defined as a talk-based therapy. The aim of psychotherapy is to treat, assess and treat severe, serious mental health problems that includes mental health problems, cognitive problems, behavioral problems. So the registered psychotherapists, they work with diverse clients, individuals, couples, and families. They can either work in institutional settings, can provide, or individual settings, private practice, can provide this kind of treatment to in group settings or individual settings or family context. Counseling, on the other hand, we realize that in the literature, sometimes they are kind of used in the same context. For example, in United Kingdom or in Europe or South Africa, for example, when they mean counseling, they might also mean psychotherapy. But in Ontario, counseling is different from psychotherapy. Counseling overall, how we understand counseling, is a supportive and empathetic professional relationship. It also provides a framework for exploration of emotions, behaviors, and thinking patterns, and also tries to facilitate healthy changes in the context of these problems. But in Ontario, we understand counseling as information giving, advice giving. So in this context, then, let's say that one question came up, saying that should every religious leaders or counselors, pastoral counselors, chaplains join CRPO? Of course not. Regulation, as we saw, doesn't require them to join CRPO. Specifically, CRPO says that if you provide religious psychotherapy, for example, specific religious or spiritual interventions in religious institutions, you don't need to join. I'll give you an example. For example, Islamic psychotherapy. If someone wants to solely practice Islamic psychotherapy, they don't necessarily need to join CRPO. However, as I mentioned, if they join, there are many, many benefits. So counseling is different. So counseling means information giving, advice giving, connecting them to different sources as well. So coming back to the overlaps in terms of definitions and how we probably loosely use certain terms and the words in the context of spiritual care and psychotherapy, but in Ontario, spiritual caregivers, they need to be mindful because we don't want to go beyond the scope of practice, or we don't want to practice something that is highly regulated under the government regulations. In Ontario, we see spiritual care providers as mental health professionals. So as I said, majority of them, they are registered psychotherapists in Ontario, specifically those who work in the hospital settings. And you will see the growing number of spiritual caregivers, especially I see most of my students, they want to become registered psychotherapists. So they want sorry, I just need to turn my camera off to cough. Sorry about that. So majority of my students, they want to become registered psychotherapists, and many in my networks, they also want to become registered psychotherapists. So CRPO encourages registered psychotherapists to have excellence in professional psychotherapy, counseling practice. So what that means? So that means that how we work in the best interest of the clients, and how we work in our abilities and competencies. And that also means that how we pursue personal and professional growth throughout our career in order to respond to diverse needs. Especially, I'll tell you, in the context of evidence-based based research in psychotherapy and also spiritual care. So that also made CAS, Canadian Association for Spiritual Care, to have a fresh look and revise the training requirements for spiritual care providers and pastoral counseling. Now we call them psychospiritual therapists, PTs. Psychotherapy, so we see it as long term, sometimes it can be brief as well, insight oriented and depth therapy. And now we have another term after this, spiritual integrated psychotherapy. And the Canadian the College of Registered Psychotherapists recognize spiritual integrated psychotherapy as one of the major modalities of psychotherapy, along with CBT, DBT, EMDR, narrative therapy, solution focused therapy. So we can extend the list of these modalities that CRPO recognizes. So again, our professional identity as spiritual care and psychotherapy and counseling in that context. So do we need all registered in the college? Again, not, we are not required, but majority of our students, again, I want to emphasize, they do want to join CRPO and be registered psychotherapists. So what psychotherapy education then integrates, and how that also shapes spiritual care training in Ontario? First of all, so it encourages us to be trained in terms of theory of human development. So that includes spiritual, moral, social, emotional, cognitive, behavioral, sexual, gender, and biological development across lifespan, and then have knowledge about the contextual and systemic factors that facilitate or impair our functioning. And then we will apply these to PTSD cases, and be trained in psychotherapy theories and intervention modalities, as CRPO encourages all psychotherapists to be mindful and then be expert in one of the modalities later on. So as I said, these kind of new regulations in Ontario opened new avenues for spiritual care and counseling practice here. First of all, we now know that there's a regulatory body, an accreditation body. They are responsible to establish new standards of ethics, and they are the ones to protect the public from the harmful practices. So in terms of this, spiritual care providers who want to join CRPO, they have to abide by these ethics that CRPO and also Canadian Association for Spiritual Care define for us. So again, that also helps us to be mindful, be aware of self in relation to professional role. So we call this safe and effective use of self. This is the CRPO language. So we reflect on how our values and attitudes might impact our clients. It also helps us to increase our awareness of oppression, power, and social justice as they impact on our clients and the also therapeutic process, and also identify and develop cultural relevant resources for our clients and recognize barriers that might affect our therapeutic relationship and services to our clients. So again, reflecting on education in the context of what we said. As you see, When we draw the map, um, in order to do this, we cannot go without a proper education. So that is why theological training institutions in North America kind of refine the theological programs, spiritual care programs, and PTs programs as well. So, but not many theological training institutions in Canada are accredited theological schools. So we do need to be mindful of this as well. But those who provide, like Emmanuel College or Wilfrid Laurier University, they do also have Martin Luther University College. They also provide this kind of training to these students, and they are the CRPO recognized training institution. So this is really very good news in terms of being a theological school and being recognized as a training institution, not only for spiritual care providers, but also for psychotherapists as well. So as per CRPO, so we have the certain commitments. So what these commitments are? So as first of all, as registered psychotherapists, mental health professionals, spiritual care providers should have excellence in practice. So again, I don't want to repeat this. Uh, First of all, we are responsible for our clients and in order to provide best care for them. Now, I would like to talk about research along with education. Why research is also a very important component of our professional identity, and how research informs and should inform our practice. And when we talk about the research, we also need to ask the question, what kind of research? So in this respect, we are talking about the evidence-based research, evidence-based practices. So this term, first of all, came to the field of medical science in 1970s. So they were started talking about certain evidence-based practices, but evidence-based practice and research was coined by McMaster Group. They are called McMaster Group at McMaster University in Ontario. So they were the ones to introduce evidence-based research and the steps of evidence-based research. And at the top of this hierarchy comes the randomized controlled trials. So they work in medical field. Probably you have seen the research all the time. They are talking about the randomized controlled trial. So why they all the time emphasize on this? Because the medical field considers them the best evidence-based research at the top of the hierarchy. At the bottom of this hierarchy comes case studies, for example. So in this kind of context, so evidence-based practice, it means, according to American Psychological Association, the quotation is as the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. So how do we understand this in social sciences, or how we understand this in psychotherapy and spiritual care, for example? So imagine the triangle. So if the triangle, we do have the certain clinical circumstances, situations, then we engage in best evidence-based research to respond to these clinical circumstances and situations, questions, ethical dilemmas, ethical cases, and then we also need to pay attention to patient values, their preferences, and things that if this evidence-based research meets the requirements or meets the expectations of the patients in context of their own needs. So here we come to, I really like to give an example of a diagnostic and statistical manual where they do have the cultural formulation interview, where DSM, for example, since 2013 again invited us to be mindful of specific cultural context that also includes religious, spiritual differences as well. So in the context of this CRPO, because they are the ones we adhere to, responsible to, accountable to, CRPO encourages research. So in order to improve our practice and also benefit our clients and also societies. This is also a very important requirement of Canadian Association of Spiritual Caregiver. And the spiritual care providers. So now we have a clear understanding that in Ontario, majority of spiritual caregivers, they consider themselves mental health professionals and they want to be trained in psychotherapy. So applying all these to PTSD cases and trauma cases, for example, especially in terms of genocidal rate. So what I would like to reflect on, how we can, as spiritual care providers, mental health professionals, can help and treat our clients suffering or suffered from traumatic experiences in the context of genocidal rape. So it is, we know that genocidal rape is a heinous crime that goes against the core of humanity. So when we look at the cases in 20th century and 21st century, for example, Khojalı genocide in 1992, Bosnia-Herzegovina in 1994, Rwanda genocide in 1994 again, Chechnya in 1999, Myanmar genocide in 2016, and Ukraine in 2022, we're still going on. So what we see a systematic plan, a carefully planned crime against women, girls. Of course, we don't deny that men can also, boys and men can also be victims and are victims of this kind of genocidal rape. My presentation specifically focuses on women. So the problem here in terms of genocidal rape and the delay of recovery, delay of post-traumatic growth and resilience in these cases. So when we look at this, we see that delayed international response to massive crimes and atrocities, and the delay of acknowledging and addressing these atrocities at international level. So this kind of experiences and delay of transitional justice delays post-traumatic growth and resilience. So let's look at the definition of genocidal rape. Probably you have watched certain movies, right? For example, The Death and the Maiden, The Brave Heart can be a very good example for this genocidal rape. Of course, they don't use this but kind of terms, but we see how these movies highlight experience of women in the context of conflicts and wars. So when we look at Gilgamesh, for example, or ancient Greek writings can be another example where they also talked about this kind of rape being used for ethnic cleansing and the systematic killing of certain parts of the group or entire population. There is one journalist, her name is Susan Brown Miller, in 1975. So what I really like her kind of insight into this, saying that probably rape was one of the most important discoveries of prehistoric time. And she gives an example of fire and also crude stone eggs that can be used and were used against in the context of war and conflicts amongst the tribes. So, but rape was another rape weapon used by during the historic times as well. But what we see in these examples, for example, in the case of Russian armed forces in Ukraine, Hocalı, and then for Serbian forces in Bosnia-Herzegovina, and Myanmar can be an example again. So what we see, there is a tendency of using this kind of weapon against other of enemy in order to instill fear. And we will talk about the consequences of this as well. But what we see is that, and it's really very horrible to see these tendencies even now. So you can look at the, for example, Ukraine or in Middle East, though there's a tendency to normalize this kind of weapon against the other, because the other is viewed as low, subordinate, and enemy. And when someone uses this kind of language, it as if they use this as to justify the action against other members of a nation or ethnic group. But Stiegelmeier also reflects that why winners specifically they use rape against women. So in genocidal rape against women, Stiegelmeier says that because women are women, especially he focuses on the experiences in Bosnia-Herzegovina, and these winners are using or were using against them the most effective weapon, which is rape. So this is really very horrible to see. However, I'm also glad that these days we talk more about these experiences. But probably in 1990s, not many people talked about this, and we don't have many research, especially evidence-based research, in terms of how spiritual care and interventions used to treat and heal women who suffered or suffering from genocidal rape. So consequences of genocidal rape, so we talk about the mental consequences, emotional consequences, physical, spiritual, and social as well. So definitely we see that majority of women who suffered or suffer from genocidal rape suffer from PTSD, they suffer from anxiety, depression, and existential crisis. So symptoms of PTSD, for example, includes flashbacks, nightmares, severe emotional distress. PTSD as a diagnosis or assessment issue. We were familiar with this before, but it was used in specifically in the context of war veterans of Vietnam in United States, and then in the third edition of Diagnostic and Statistical Manual, we see the PTSD described under the anxiety disorders, but in 2013, Diagnostic and Statistical Manual separated PTSD from anxiety disorders and has a whole chapter on PTSD. So these are the ones, for example, spiritual caregivers in Ontario, and also I'm sure that in other parts of North America too, and Europe, they learn about PTSD in order to try to help the clients who suffer from PTSD symptoms. So in terms of PTSD, what we see, and when we apply these to women who suffer genocidal rape, we see number one symptom, it's avoidance. So they try to avoid thoughts, feelings, or reminders of their trauma because they don't want to be re-traumatized. That is why in our spiritual care training, we emphasize trauma-informed spiritual care, trauma-informed psychotherapy, trauma-informed spiritually integrated psychotherapy. because when we use trauma-informed psychotherapy, trauma-informed spiritual care, we first focus on safety of our clients and no harm. So safety is really very important in the context of genocidal rape as well. Uh, and we also see kind of negative changes in thinking and mood. But the majority of our clients, they suffer from negative thoughts, but also they suffer from emotional numbness and memory problems. So what is interesting in PTSD cases and other trauma-related cases is that memory has been affected. So this is really an issue, specifically in the context of EMDR, eye movement and desensitization, reprocessing. They kind of focus more on memory in order to help the clients. So in the context of this, we see that as the clients, for example, they, from cognitive perspective, they try to accommodate or assimilate or over accommodate the kind of negative thoughts, and this is very important for spiritual caregivers to know in order to understand the processes in psychotherapy practice. So we also see changes in physical and emotional reactions as well. For example, we see a woman who suffer from genocidal rape, in cases of other PTSD cases, they startle. They have, some of them, they might have self-destructive behavior, or they have difficulty in terms of coping strategies. But what is most important, especially in context of genocidal rape, is that they risk communal and multi-generational suffering. So when we revisit cases in Rwanda, for example, a Rohingya woman in Myanmar, and Bosnia-Herzegovina, Ukraine, for example, we see how all these have long-lasting impacts on communities. So not only individual women who suffer from genocidal rape, but the whole communities get traumatized. And when the whole communities don't know how to function, don't know how to cope with this genocidal rape, there is also delay of recovery, resilience, and post-traumatic growth in the context of women as well. So again, when we look at Rwanda genocide, still survivors, they do have ongoing trauma. Rohingya women in Myanmar, they still have their ongoing trauma because communities still don't know how to manage this trauma, how to respond. The communities whole, they became dysfunctional. Families became dysfunctional. That not only includes communities, non-religious communities. We are also talking about the religious, spiritual communities as well. So in this respect, what we see in reality is that there is deep and profound suffering. And this suffering extends beyond individual victims and goes and extends to entire communities as well. So in the context of this, the question is that how spiritual care and spiritual integrated psychotherapy fosters resilience, what we see in the literature. So first of all, as the resilience means that someone has the ability to cope. They have the ability to maintain equilibrium. They have the skills to develop effective strategies despite serious threats. So in the context of this, for example, Marzilia and other researchers, they looked at this, saying that not everyone, and they give statistics as well. For example, one of the statistics is that 80% of us, including us as well, every 80% of population uh, will meet at least one or met at least one traumatic major event in their lives. And 50% of the population usually have this more than one major traumatic experiences in their life. However, not every people who are subject to this kind of traumatic experiences develop PTSD or trauma related disorders. However, those who do, the question for us is that why certain people have the capacity to bounce back, have the capacity not to develop PTSD or trauma-related disorders, but others they do. So in this respect, again, we are turning back to evidence-based research to inform our practice in order to learn and also apply this in our clinical practice. So resilience in general means a capacity to recover quickly from difficulties, from tough times. It involves the ability to adapt well. So we adjust well in the face of adversity, trauma, tragedy, threats, and significant sources of stress. So evidence-based research informs us that these people, these individuals have protective factors. That's why they develop resilience fast if we compare them to other client population who cannot develop this kind of protective factors, or they don't have this kind of protective factors. What we mean by protective factors? We mean family resources, community support, cultural practices. That also includes spiritual and religious practices as well. Resilience in general helps women to transcend their traumatic experiences. It is important in terms of protective factors to bounce back, and we can give the resilience of women in Bosnia and other conflict zones. Of course, we still don't deny the fact that these women still, some of these women still suffer from trauma-related disorders. What is most important to understand that in these cases, trauma also becomes multi-generational trauma. So similar, we also see, for example, indigenous populations in Canada. So imagine that the whole more than 90% probably, I don't know its exact figure, but I remember in one presentation on the multi-generational trauma in indigenous populations in Canada, more than 90% of indigenous populations were killed. That was they were subject to physical genocide and also cultural genocide as well. So in that presentation, the presenter gave some kind of statistics to understand this, asking us to reflect that imagine 10 people in the room, and imagine that 9 out of 10 were subject to genocide. Only 1% survives this genocide, and this 1% developed PTSD trauma, and these PTSD, these trauma-related disorders became multi-generational trauma. And then research again focuses on why certain communities develop resilience faster because of protective factors, but some communities cannot because they are still subject to systematic racism, systematic xenophobia, systematic eradication of cultural protective factors. So we again need to take that into consideration in spiritual care and spiritually integrated psychotherapy. So in Ontario, again, I'm coming back to Ontario because in Ontario, spiritual care providers are trained. Some majority of spiritual care providers, especially those who go to Emmanuel College program or they go to Martin Luther University College program, so they learn about different modalities and techniques and how to use these modalities, techniques in spiritual care. So in the context of genocidal rape and trauma-related disorders, they learn about trauma-focused cognitive behavior therapy, cognitive processing, prolonged exposure therapy, narrative therapy, eye movement desensitization, and reprocessing. They also learn how to practice safe space with their clients, again, from trauma-informed perspective. Safety is really very important, and we are responsible, we are accountable to create a safe environment for survivors so they can build trustful relationship with us and share their stories. So we can review these case studies. Probably don't have much time to go to the details of this case study, but there is one study, Bosnian woman using narrative therapy, for example. And in another case, Uyghur woman subject to Chinese systematic genocide against Uyghur women and the Uyghur populations in China. So her experience in a camp, for example, and how after that community support, family support helped her to bounce back. So these kind of interventions in spiritual care give more hope. Of course, we might not use all these therapy. We can solely use spirituality, spiritual concepts, spiritual framework to help women to create hope. But these modalities and techniques are also very useful. Specifically, these are we are talking about the evidence-based research, and there are many evidence-based research how these kind of modalities and techniques help our clients who suffer from trauma and trauma-related disorders. So I don't want to go over of all these, but when we compare these to medications, briefly we can say that there are many research that compare CBT, for example, to medication, and they did find out that there is no difference actually in terms of effectiveness, or saying that medications are better than cognitive behavior therapy, or cognitive behavior therapy is better than medication. So the most important thing is that how we learn what is most important. Of course, in Ontario, CRPO informs us we cannot diagnose, we can only assess, and there's a difference between assessment and diagnosis in this context, and we cannot prescribe any medications because this is beyond the scope of our practice. But it is important we are familiar about these medications or have general information about the effectiveness of medications in majority of these cases as well. So again, at Emmanuel College, we do have different courses. We provide different courses, and the future spiritual care providers, our students get trained in these modalities, and then they go to clinical settings. Some of them go to community-based settings where they do practice these techniques. Some of the clinical sites, I would like to say that they are specifically kind of focused on one modality. For example, some setting might say that they are expert in applying DBT or psychoanalysis. So our students also gets really extended training under the supervision or qualified registered psychotherapists or psychologists or other healthcare professionals. So what is important again in spiritual care? So we are coming back to evidence-based research, and the question is that the modalities we described, are they enough in terms of, in the context of genocidal rape? There are many the research studies on this, and they emphasize that without transitional justice, again, resilience and post-traumatic growth delays. So there are many research studies in terms of transitional justice. We don't have many transitional justice focused papers in spiritual care and spiritual integrated psychotherapy, specifically in the context of genocidal rape. But why transitional justice important? Victims, when we review the cases, and also when we review the research, what we find out, the clients, they tell us that truth telling and forgiveness are important to develop resilience and post-traumatic growth. Of course, forgiveness is not to forgive the perpetrator or the one who committed crime against them. Not in that context. To forgive in order to heal. So that is some of the research participants reported. But also these research studies also focus on establishing justice and accountability. Again, going back to what I said, delay at international level and ongoing wars, all these are triggers not only to those women who go through this right now, but also to women and communities who did go through in the past as well. But we do have challenges, and research focuses on these challenges as well. First of all, it is very difficult to bring perpetrators to justice. One of the reasons of this is that majority of women come from shame-based cultures, and they don't want to report what happened to them. They simply want to forget in order to heal. So that's what they feel. They feel that they don't need to go forward and talk about this. Some people do come forward in order to say that, okay, this happened, in order to record what happened to them in the war. But some they don't. And again, because of shame, because of stigma, not many communities are ready in terms of tackling stigma and shame. So that is why women are not prepared. In psychotherapy practice, we need to be mindful of this, and we need to be careful how we talk about this, how we build trust and safety so they can talk about the individual experiences, community experiences in order to help. One of the challenges is that there was one research saying that especially United Nations papers also focus on the autopsy. Some family members, they don't want autopsy after some women die because of genocidal rape, or remains of body are not enough in order to investigate, and the current criminal investigations, they don't have enough resources in order to go beyond and find out that what happened to them before they died. As you know, the main focus of this kind of autopsies in criminal investigation is to focus on the immediate cause of the death, rather than to focus on what happened to the person before they were killed or before they died. So there are many reasons of the challenges and in transitional justice, but briefly, we need to remember that transitional justice is really very important in terms of post-traumatic growth and resilience. And again, spiritual care, how we can promote mental health among women who suffered from genocidal rape. Focus is should be always on enhancing victims' well-being. For this, spiritual care should focus on how we assess risk factors, and also we evaluate protective factors. That includes not only women's individual risk factors and protective factors, but also how families prepared, how communities develop protective factors or risk factors within the family systems and also community. Spiritual care providers also need to be mindful of importance of social support network, because they are the ones also to enhance resilience and mitigate symptoms. In these terms, family, friends, communities support are really very important. They are the parts of social support network. I would also add the international community as well, because when international communities prepared and respond to this kind of trauma without delay of transitional justice or criminal investigation, it also they also become part of this safe healing community. And key points in this slide is that mental health promotion should be part of spiritual care. It should involve enhancing how we use spiritual interventions, especially in terms of meaning making, connection to divine, universe, or nature, whatever we call it, cognitive and social and emotional skills. And again, social support is crucial, and the religious spiritual communities should think about it and develop this kind of support networks for women in order to promote resilience. Um, and more on the role of spirituality and why spirituality becomes part of the evidence-based research in spiritual care and spiritual integrated psychotherapy, and also in other fields as well. For example, this morning, I forgot the name, but they talked about the spiritual care intervention and spirituality in nursing literature. We also see a growing body of literature in psychology and social work as well, and occupational therapy as well. So we are not the only ones to use spirituality as important intervention. Other allied health professionals, they also use spirituality as important technique and intervention. Why we use spirituality then? Because spirituality provides source of hope, strength and comfort for survivors. It helps victims to cope with trauma and find new meaning in life. However, we also need to be careful because not all spiritual interventions might be timely, or we can use these kind of interventions in wrong place with wrong clients. So in these terms, we need to be really very careful. So one of the caution in the literature is that sometimes when we talk about spirituality in spiritual care psychotherapy, clients might have some transference, understanding that we push them to forgive or not to seek justice. Spiritual care literature focuses on this at all, saying that of course we don't push the clients to seek forgiveness or not to seek to forgive the perpetrators or to avoid justice. We never recommend this, and this should not be recommended at all from social justice perspective and from divine justice perspectives as well. But what is most important for us to know is that we need to be careful how our clients respond when we use spiritual language in psychotherapy and spiritual care. And the focus should always be on vulnerabilities and how our clients find new meanings in terms of these, what resilience looks like for them in terms of post-traumatic growth and resilience. And in this terms, spiritual care providers, therapists need to use spirituality with caution and sensitivity. Overall, spirituality is a powerful resource for resilience and post-traumatic growth. So, in conclusion, spiritual care to should be included in treatment plan again, because they are very helpful to our clients who suffer from genocidal rape. So thank you very much for your attention, and hope I was able to cover some insights from the research in this presentation.
Thank you so much, Nazila, for your presentation. Primarily as a clinician who happens to be to work with a particular approach and model, you have illustrated for us and inform how other than religious bodies can and should regulate the practices in spiritual care. That's very extremely important. So your detailed account is very important for us. I regret not having included in my introduction of you the fact that you come from Azerbaijan, and that you return to your country and you work with women there and in the region, and that you are actually involved in this question of advocacy and actual spiritual care with women suffering violence, and that and the fact that your inspiration, for example, in studies like your study of how the Quran, the Holy Quran, can inspire, inform, and guide in the prevention of violence against women. So thank you so very, very much. Your video will be included in the website, and we'll try to have it in a way that is really easy to follow that. We have a few minutes for some questions or comments before 11:45 is the time to close this session. So is there a comment, a question? Perhaps from the those online there?
I could ask a question.
Please. Yes, Carrie.
Harry Doring from Denver. Nazila, thank you very much. That was very, very moving and profound presentation. Very helpful to hear how Ontario is navigating accreditation of pastoral psychotherapists and spiritual psychotherapists. I wonder about the research from Ken Pargman and Julie Eckstein and others on religious and spiritual struggles that highlight how aspects of religion and spirituality can be helpful and harmful. And I think a lot of the research on spiritual struggles also gets us into the territory of moral struggles. Complex to think about in terms of those who are victims, but there has been evidence for many years, particularly Judith Herman's research on shame, about the moral and spiritual struggles of rape victims. I wonder if you might comment on that.
Thank you so much, Carrie. We also learned a lot from your research studies as well. It was very informative, informs our practice in spiritual care and spiritually integrated psychotherapy. Actually, your book is a required reading in my course, you know, that I teach Supervised Psychospiritual Education, and I extensively, and our students extensively use that book as well. You are very right. We do have lots of research coming from psychology perspective, focusing on moral injury and moral distress and spiritual struggles, religious struggles. We also see lots of growing literature in spiritual care, because right now, because of evidence-based research in the, as I feel, emphasis on this helped us spiritual care providers to conduct many research, qualitative, quantitative research, case study research, for example, to focus on this and kind of draw conclusions and apply this in our practice. So we do see lots of research literature on that, and especially Pam McCurl, for example. I would like to mention her name as well. Her thesis and later on book, and very recently her published book focused on trauma, moral injury, and we see more on this. This is really very important, and in our training it's also really very important, because again, in 10 years ago or 5 years ago, for example, we might not thought about, reflected on, let's say that trauma-informed care, right? We didn't have this kind of language 10 years ago. But moral injury, for example, it wasn't included in our language a lot. But now, growing bodies of literature, research, help us to reflect deeply, and we look on this from the praxis, you know, action, reflection, and reaction perspective, and we carefully and intentionally, mindfully apply all these in our training and also practice. They are really very important, and I'm glad that you did mention few names, but we also see many research coming out. But we do need more. It doesn't mean that we have enough. We don't have enough. Again, thinking about the spiritual assessment tools, for example, do we have adequate spiritual assessment tools in terms of trauma cases? Of course, Fichet, for example, says that we do have enough spiritual assessment tools. We don't need to produce more. Well, I think that his article mentions that we do have more than 800 spiritual assessment tools coming from northern perspective, coming from spiritual perspective. But of course, they are helpful too in the context of genocidal trauma. But we need to integrate trauma-informed language in these assessment tools and interventions. So this is my kind of reflection, and I hope to see more on this, to see also in cases of moral injury, moral distress as well.
Well, again, thank you so very, very much, dear colleague. I know we'll remain in contact, and we wish you well in your pursuits far away, as well as in Ontario and in other places in Canada. And hopefully our contact will be not only via the internet, but more directly as well. So blessings to you.
Thank you. Thank you.